Good morning, everyone. Okay, fine. So this is Dr. Pranidhi, your ophthalmology faculty, and today we are going to have a quick discussion about lens. Okay, that is a very important topic from exam point of view, from your uh, examination, whether it is related to your professional examination or the NEET or the INSET examination. Now, when you want to start the topic of the lens, we want to have a quick revision of the anatomy of the eyeball as a whole. Okay, we know that there are three coats of the eye. Okay, we know that we all know that what are the three coats of the eye. Outer one is the fibrous coat, which comprises of the cornea and sclera. So some of the things I will be pre-assuming that all of you know the basic things. Even if any of you has a doubt in those basic things which I will be putting, please you can leave them in the chat and we will discuss them. Okay, so I'm assuming you know that the three coats of the eye are the outer one, the fibrous, the middle one is the vascular, which is comprised of uvea and choroid, and inner one that is the neural layer, which is made up of retina. Okay. So lens is not a part of any coat of the eye. Now what the lens is? So as you can focus on this image, the outermost sclera and the cornea, the inner one, the mid one, the vascular one, this is the choroid, and the innermost is the retina. So where the lens is basically present in a cavity in the innermost coat of the eye, in the cavity. Here the lens is present. This is a cut section of the eyeball, and the lens, as you can see, this lens divides the eye into two parts. So lens basically divides the eye into two parts, and these parts are the anterior and the posterior segments. So the lens basically divides the eyeball into two parts. What are these two parts? This is the anterior and the posterior. Anterior and posterior segments of the eye. Similarly, as you can see, this part is the iris. The iris divides the anterior segments again into two parts, and these are the anterior and the posterior chambers of the eye. So the lens divides the eye into anterior and posterior segments. Now what the lens is basically? Lens is basically a transparent structure, convex, a biconvex structure, which is contributing towards the refractive power of the eye. There are two structures contributing to it, cornea and the lens. Cornea contributes to around 43 to 48 diopters, while the lens is contributing to around 12 to 18 diopters, giving the eye its total refractive power as 60 diopters. So for the lens to contribute to the refractive power, it has to be transparent. So it is a transparent structure contributing to around 1/4 of the refractive power. It also plays a role in accommodation. We'll discuss it. It plays a role in accommodation. It is a biconvex structure in which the posterior surface is more convex than the anterior surface. Okay. So this is the cut section of my lens. So here you can see the anterior surface is less convex and the posterior surface is more convex. So I can say that the lens is made up of two circles, out of which anterior surface is a part of a bigger circle and the posterior surface is part of a smaller circle, meaning the posterior surface is more convex than the anterior surface. The refractive index of the lens is 1.386 and it is located in a groove within the eyeball which is called patellar fossa. So the groove in which this lens is suspended is known by the name of patellar fossa, and it is suspended in its normal position. Here you can see, I hope you can appreciate these structures. So it is suspended in its position with the help of these ciliary zonule. So ciliary zonule suspend in its normal position. Okay. And now what is one point I left, that is accommodation. So what is this accommodation is? Accommodation is the ability of the eye to look at the nearer objects. Whenever we look at the nearer objects, we need the eyeball to have more power. We know that what is refraction. Okay. What basically refraction is, what is the function of cornea and the lens is. So this is my eyeball, this is my lens. So the function of the cornea and the lens is to refract the parallel rays of light coming from distant object to retina, to let them focus on the retina. This is the function of the cornea and the lens. But whenever we look at a nearer object, from the nearer object, rays coming out from nearer object are diverging, while the rays coming from a far off object are parallel. Okay, so this is if I am looking at this nearer object, the rays coming from the nearer object are diverging. So this is, so if there are diverging rays which are coming from a nearer object, the eye needs more power to focus them over the retina. Okay, and this increase in power is shown by lens, not the cornea. So cornea basically does not increase its power when we are viewing the nearer objects, but the lens which increases its power and lets the image focus over the retina. And this is known by, and this process is basically is known as, this process is basically known as accommodation. And how does it helps in accommodation is by increasing its power, by increasing its surface area and by increasing its power. Okay. Now, how does the lens develops? What is the embryology of the lens? So we know that basically at 22 to 27 days of gestation, optical vessels or the optic vessels, it arises from the neuroectoderm, and from the surface ectoderm, this process, the formation of the optic vesicle is happening at the days of 22 to 27. But at 27 days of gestation, there appears a thickening in the surface ectoderm. There appears a thickening in the surface ectoderm, which is known by the name of lens placard. And this lens placard then invaginates, it invaginates and forms a lens pit. It forms a lens pit. And in at 33 days of gestation, this lens pit it gets separated. It gets separated from the surface ectoderm and forms a lens vesicle. At 33 days of gestation, you must remember that at 33 days of gestation, this lens vesicle gets separated from the surface ectoderm. And then within this lens vesicle, there develops the primary lens fibers, okay, at 50 days of gestation. And at 52 days of gestation, there develops secondary lens fibers. Even if you cannot remember all the days, you must remember this, that at 33 days of gestation, the lens vesicle, it gets separated from the surface ectoderm, and the full formation of the lens in the form of primary and secondary lens fibers is complete by 56 days of gestation. So you must remember when the lens vesicle gets separated from the surface ectoderm. That is the one most important if you cannot remember the whole of the embryology. So this is again a diagrammatic representation of how the lens is formed. So there is firstly there is thickening of the surface ectoderm, then formation of a lens pit, then lens pit gets separated in the form of a lens vesicle, and then there is formation of the primary and the secondary lens fiber. Okay. Now this is a cut section of the lens which all of you want to remember by heart. So earlier we studied about the gross anatomy of the lens. where it is located in the eye. Now we will look at the gross anatomy of the human lens in a magnified view. So I want all of you to please focus on this image. So whenever the lens gets developed, it mostly has three layers. Okay, firstly you have to remember the lens has three layers. The outermost layer is the capsule of the eye. Okay, then is the cortex, and the innermost is the nucleus. Okay, fine. So outermost, you will get a capsule which is present anteriorly as well as posteriorly. This is the capsule of the eye. Inside the capsule, anteriorly we have this, as you can see, these are the cells. So anteriorly we have the epithelium of the lens. Okay, these are the epithelial cells. As you can see, they are cuboidal in shape. As you can appreciate, these are cuboidal in shape. But as we go from the center towards periphery, please focus here. As we go from center to periphery, the shape of this lens changes. Can you appreciate? From cuboidal shape, they are becoming columnar. From the cuboidal, they are becoming columnar. So as we go from the center to periphery, they change their shape from cuboidal to columnar. Okay. So I'm removing this again. So as we go from center to periphery, they becoming cuboidal to columnar. So what is the purpose of this? The central cells, which are cuboidal in shape, they do not divide. Okay, they do not divide under normal conditions. But the cells which are columnar, which are present in the periphery, in the pre-equatorial or the equatorial region, they have the capacity to divide. Okay, they can normally divide. And what is the function of this division of the cells is the division of this anterior epithelial cell is what is giving rise to the lens fibers. Lens fibers. So basically, these lens fibers, these columnar cells, they are giving rise to these lens fibers, which are then migrating posteriorly. As you can see in this image, they are migrating posteriorly and they are filling the lens. They are forming the lens fiber and they are filling the lens posteriorly. And then they will keep on dividing, they will keep on dividing, and they will keep on filling the cells from posterior to anterior. Okay, and they will fill whole of the lens. They will fill whole of the lens from posterior to anterior. Okay. The innermost fibers, as you can appreciate, the innermost fibers will be the oldest fibers, and the newest fibers they will get add upon in the periphery. Okay. So the innermost fibers, they are known by the name of nucleus, and they are the oldest fibers. They are the oldest fibers, while the newest fibers, they are joining around the knee. Okay. So the lens fibers, they are secreted throughout the life. They are secreted throughout the life, and the nucleus has the oldest fibers. The nucleus has the oldest fibers, while the cortex has the new fibers. So you have to remember three things: capsule, cortex, nucleus. Nucleus has the oldest fibers, cortex has the newest fibers. And one thing you have to remember, how these fibers are getting secreted. They are secreted with the help of anterior epithelium, which is dividing in the equatorial or the pre-equatorial region. They are dividing in the pre-equatorial region. And the next most important thing, as you can appreciate here, I am removing this. Can you appreciate there is no epithelium in the posterior part? There is no posterior epithelium. There is no posterior epithelium. So is this clear up to here? Is this clear? The lens has three parts. The anterior epithelium. As we move towards periphery, it changes from cuboidal to columnar cells and keeps on adding the lens fibers. From they migrate towards the posterior part and they keep on adding these fibers. The fibers which are innermost, They are the oldest ones and they are known by the name of nucleus. And the outermost fibers shown by this blue color, these are the cortical fibers, and this the red ones, they are the nuclear fibers, which are the oldest fibers. Is it clear now? So we'll talk a little about the three layers of the lens. The capsule, it is basically a basement membrane, and it is the thickest basement membrane of the body. The capsule is the thickest basement membrane in the body. It is thickest in the pre-equatorial region. So what are these regions of the lens? The central one, as we know, the central one which is containing the cuboidal cells. Then from the central one, we have the pre-equatorial region, and at the equator, we have the equatorial region. And we know that what equator is. Does everybody know what equator is? Equator is the imaginary circles. These are the imaginary points or circles where the dimensions of the lens are highest. So these are the imaginary points. Okay. So equator are the imaginary points in the eye where the dimensions or the length of the lens is the highest in number. And what are these 2 points? These 2 points in the lens, they are known by the name of poles of the lens. These are the poles of the lens. These are poles of the lens, and these 2 points are the equator of the lens. So the anterior and the posterior markings are the poles of the lens. Okay. So the capsule is thickest in the pre-equatorial region, and it is thinnest at the posterior pole. That is the most posterior point of the lens. The capsule is thinnest. Okay. And it consists of type 4 collagen. We can easily assume it because it is basement membrane. So it has the type 4 collagen. Epithelium is present only anteriorly. As I mentioned, it is present only anteriorly. It is cuboidal in center and columnar in periphery. And the new cortex contains the new lens fibers, and nucleus contains the old lens fibers. Is it clear? So is the normal anatomy, embryology of the lens clear? Then we can move towards the pathological part. Just give me a thumbs up if we can move forward. This was the more conceptual part, and rest more factual part is coming. We will be able to complete it soon. So is the conceptual part clear? We will move to the factual part. So now we will go towards the pathological aspect of the lens. So from the pathological aspect, before coming to cataract, we will come to another topic, that is ectopia lentis. So ectopia lentis is, as the name suggests, ectopia lentis is basically whenever there is subluxation of the lens. There is subluxation of the lens, okay? That the lens, it displaces from its position. Here you have to remember 2 points. What is subluxation and what is dislocation? Subluxation is whenever lens moves from its normal position, but it is still contained in that patellar fossa. We discussed that lens is present in a cavity which is present in the patellar fossa suspended by the ciliary zonule. Whenever it changes its position, like it dislocates or subluxates to a point, but it is present in this plane only. It is present in this plane only. This is known by the name of subluxation, that is partial dislocation. But whenever it dislocates completely, either in the anterior chamber, it comes in front of the iris, or it goes beyond in the vitreous cavity, then it is known by the name of dislocation. When it's completely dislocated from its position, this is dislocation. Okay? Then this subluxation, it can be acquired or congenital. Whenever we talk about the congenital subluxation, we have given it name, that is ectopia lentis. It can be acquired, it can be by birth. Okay, whenever it is by birth, it is ectopial lentis, otherwise it is acquired. So, what are the acquired causes? When a child is born with the normal position of the lens, but after the birth, it gets subluxated. So, what are the acquired causes of the subluxation of lens? Firstly, it can be trauma. Because of the trauma, there is tear in the ciliary zonules and the lens gets separated from its normal position. High myopia. High myopia causes the ciliary zonules to weaken. It weakens the ciliary zonules, so lens can be easily separated from this. Okay. So trauma and high myopia, these are the two main causes of the acquired subluxation of the lens, which you must remember. Okay. And now we are coming to ectopial lentis, that is, which is present since birth. And in this part, as you can appreciate here, can you appreciate the lens has displaced from its position? It has displaced in this position, and can you appreciate these lines? Can you appreciate these lines? These are the broken ciliary zonules. These are the broken ciliary zonules. But it has not completely dislocated. It has partially dislocated. So we have given it a term of subluxation. And again, can you appreciate it has subluxated upwards? It has subluxated superiorly. Okay. So in the ectopia lentis, I want you to remember three diseases. I want you to remember three diseases which you must remember. One is the Marfan syndrome. Next is the homocystinuria. And the third one is the Marchesni syndrome. Okay. There are multiple other causes of the ectopia lentis, but we want to remember these three. You must remember these three: Marfan syndrome, homocystinuria, and Weil-Marchesni syndrome. And we will discuss a few things about these. Okay. So what are the, we will discuss a few things because these things, they have been asked recently many a times in the question about this homocystinuria. So firstly, we will discuss the gross findings which are seen in the Marfan syndrome. The patient of Marfan syndrome presents with a tall stature and arachnodactyly. The patient presents with arachnodactyly and tall stature. Similarly, a patient of homocystinuria again present with tall stature and arachnodactyly. Patient will have a tall stature. Patient will have long extremities, long fingers, and that is known by the name of arachnodactyly. And the patient will have tall stature. While a patient of Weil-Marchesni syndrome will have a short stature, will have short stature or brachydactyly. Okay. So patient of Weil-Marchesni will have short stature and from Marfan syndrome, we know that we have studied Marfan syndrome a lot. So patient will have tall stature, patient will have high arched palate, or in the exam they can give you other hints like patient is a known case of mitral valve prolapse. The patient have aortic root dilatation. These are some of the other hints they can give you in Marfan syndrome. Okay. In Weil-Marchesni syndrome, the patient has tall stature. In homocystinuria, there is increase in the level of homocysteine. So the patient can have blonde hair. They can have blue iris. So these are the other hints which can be given in the exam. The ectopia lentis seen in the Marfan syndrome is the superior and temporal subluxation. So the lens is dislocated or subluxated superior temporally. In homocysteine, it is dislocated inferonasally. In real Murchison, again, it is dislocated infero-nasally and in. So you must remember firstly where the lens is subluxated in these three diseases. In Marfan's superiotemporally, in homocystinuria infero-nasally, and in Wheel Marchesni infero-nasally and anteriorly. Okay, and what is the stature in these? Marfan's tall, homocystinuria tall, Wheel Marchesni short. And in homocystinuria, they can give you these hints also. In homocystinuria, how can we treat it? We can treat it with the treatment of vitamin B6, vitamin B12, and folic acid. These are the treatment of homocystinuria, while Marfan syndrome and Weil-Marchesani, they are hereditary disorders. They cannot be treated as such, but homocystinuria can be treated with the help of vitamin B6, B12, and folic acid. Okay. So this was the first pathological part of the lens, that is the ectopial lentis. Now we will come at the important part, that is the cataract, that is opacity in the lens. What cataract stands for? Cataract is basically any opacity in the lens is known by the name of cataract. So we divide the cataract into two parts. We divide the cataract into two parts or the two types. We have a different classification of the cataract. We have two classifications. One is the etiological classification and another one is the morphological classification. So we divide cataract into two classifications, etiological and morphological. As the name suggests, morphological means which part of the lens has developed opacity. Then that's how we divide that. It is anterior polar, posterior polar, will come to it, depending upon the part of the lens which is opacified. Etiological classification is based upon the positive reason why there is opacity in the lens. That is the etiological classification. Among the etiological classifications, senile cataract is the most common type. Senile cataract, that is the age-related cataract. This age-related cataract is the most common cause, that is the senile cataract. And sometimes we do not consider senile cataract as a pathological process. It is a age-related physiological process. So senile cataract is age-related opacification in the lens. Other causes of the lens opacity, it can be trauma. Trauma can lead to lens. Okay, lens can be caused again in high myopia. In high myopes, it can be caused. It can lead to cataract. It can be due to the presence of some radiations. They can lead to cataract. It can be related to some systemic diseases like diabetes mellitus, which are acquired, that is diabetes mellitus. It can be related to some hereditary systemic diseases, or it can be due to severe diarrhea. Severe diarrhea can also lead to cataract because severe diarrhea will lead to loss of nutrition of the lens. Lens is depriving or getting its nutrition from the aqueous humor. So the aqueous humor is basically responsible for the nourishment of the lens. Whenever there is loss of this nourishment, as seen in severe diarrhea, patients can develop cataract. Okay. So again, this is the etiological classification, and for the morphological classification, please look up to this image. So we know that the three layers of the lens, one is this capsule outermost, then is the epithelium, which is basically giving rise to cortex and nucleus. Okay, clear to here? So whenever there is opacity in the centralmost part, whenever there is opacity in the centralmost part, it is known by the name of nucleus cataract. This is known by the name of nuclear cataract. Whenever opacity in the nucleus, this is nuclear cataract. Opacity in this cortical fibers, opacity in this cortex or the cortical fiber is cortical cataract. This is cortical cataract. Opacity in the poles. Opacity at the poles is the anterior polar or the posterior polar cataract. Okay. Now there are two definitions left. Any opacity beneath the anterior capsule and any opacity in front of posterior capsule. They are known by the name of subcapsular cataract. Subcapsular cataract. If it is present beneath the anterior capsule, this is known by the name of anterior subcapsular cataract. And just in front of the posterior capsule, this is the posterior subcapsular cataract. Okay, the anterior subcapsular, posterior subcapsular, nuclear, and the cortical. Cortical can be present here, cortical can be present here, it can be present here. Okay, so this is the morphological classification of the. Okay, now we will discuss how these different types of the morphological classification looks like. Again, as the etiological classification, patient can have senile cataract also, uh, uh, patient can have congenital cataract also. There can be different etiological reasons which can be responsible for that. There can be involvement of some radiations, can be some hereditary disorders, acquired systemic disorders like diabetes or severe diarrhea. Now we will look at how these uh, morphological classification of the lens looks like. So when I said the central part of the lens, it gets opacified. This is known by the name of nuclear cataract. I hope all of you can appreciate or all of you know that the lens is present as a whole. The lens is present as a whole. This whole of this is lens. But the part which we are seeing as a opacified structure, basically we have produced a cut section of the lens. We have produced a cut section of the lens. As you can see, we have made a cut section of the lens known by the name of slit. We have made a slit. As you can appreciate, I'll remove it. Can you appreciate this thing? This is a slit or the cut section of the cornea, and this is a cut section of the lens, which we make through slit lamp. The slit lamp, basically, as the name suggests, slit lamps make a slit or the cut section of the cornea and the lens. But the lens is present throughout here, okay? The lens behind the iris, this throughout is the lens. But as you can see, this peripheral part of the lens, this is black. It means this is not opacified. This is normal. This is transparent. But only this central part has opacified. So we know that the central parts gets opacified in the nuclear cataract. What if the if we have the image, but if we want to see here only, what if this was the cortical cataract? So this part would have been black, and this part would have been white or the opaque. So this would have been then cortical cataract. So here, since the central part is opacified, this is known by the name of nuclear cataract, and we are seeing it with the help of slit made by the slit lamp. And here, can you see again, this nuclear cataract has increased. The nuclear grading has increased. It has assumed more. I'll tell you the grading of the nuclear cataract. This nuclear grading has increased in grading, and the nuclear cataract has advanced. And you can see some parts or the periphery of this lens is still black or still transparent. Okay. So how do we divide this nuclear cataract? We can divide the nuclear cataract on the basis of color coding. Okay, we give 4 gradings to the nuclear cataract. In the first, these are the 3 colors, which these are the 4 colors which we get in the grading of the nuclear cataract. So one is the first NS1 is the greenish color or the yellowish green color. is the grade 1. Okay. Yellow color is the grade 2. Amber color is the grade 3. And brown color is grade 4. Sometimes you have black color, then it is grade 5. So we know that nuclear sclerosis or the nuclear cataract is nuclear cataract 1, nuclear sclerosis 2, 3, 4, and 5. We give the name of NS. We say it as NS, meaning nuclear sclerosis. We give nuclear cataract as the name of nuclear sclerosis, meaning the nuclear cataract is formed due to the sclerosis of the lens fiber. It is made up of, it happens due to the sclerosis of the lens proteins. Basically, the lens contains water and it contains proteins. There are two types of proteins which are present in the lens. One is the crystallines and other are the albuminides. Crystallines are alpha, beta, gamma, and beta is the most common, which is the most excessive protein which is present in the lens. These crystallines are water soluble and these albuminoids are water insoluble. These are the two types of proteins which are present in the lens. With increase in age, the insoluble protein increase in quantity. Okay, whenever the age increases, these insoluble proteins they increase in quantity and they lead to sclerosis of the cataract, which presents as nuclear cataract. That is why we call it as nuclear sclerosis. Okay. As can you appreciate this next image? Can anybody tell me which type of morphological classification of lenses is or the cataract is this? Which type of cataract is this? Yes, this is the cortical fiber. So as you can see, these are the wedges. In the cortical cataract, you can get these wedges or the spokes which are radiating from periphery towards the center, and this is the cortical cataract. This is the cortical cataract, presence of wedges. And on retroillumination, this is how cortical cataract, can you appreciate these wedges? This cortical cataract looks like. Okay. Now, anybody tell me which type of cataract is this on retro? Whenever you get a fundal glow, you are getting this orangish color. It means this is being shown in retro illumination. This is a function of the slit and this is on retro illumination. Which type of cataract is this? There is a central opacity. This is a central opacity. This is posterior subcapsular and also the posterior polar. Posterior polar cataract is also seen like a posterior subcapsular cataract or the posterior polar cataract on retro illumination. They look like a central dot. They look like a central dot, central blackish dot. This is not nuclear cataract because nuclear cataract will be present in the center. In retro illumination, we diagnose or retro illumination is best to diagnose the posterior subcapsular cataract. And nuclear cataract, as I showed, they are best seen on the cut section of the slit. And on this cut section, this is how posterior subcapsular cataract looks like. Okay, this is how the posterior subcapsular cataract looks like. It starts from the center and then it's involved whole of the lens, the posterior subcapsular part. And here, can you appreciate? It has involved the posterior subcapsular part, and this is the PS. In this image, firstly, it will start from the center and then it will stretch towards the periphery. will spread towards the periphery. This is the difference which is shown in these two images. Here it is present in the center only, but here it has spread towards the periphery also. But it is present in that plane only. Okay? Now this pearly white cataract. So these we discussed about the two classification of the cataract, morphological and etiological. There is another classification of the lens depending upon the maturity of the lens. That what is the grading of the cataract which is present, whether the cataract is immature or cataract is mature. Okay? So whenever there is some transparency which is present in the lens, we call it as immature cataract, while in mature cataract, whole of the lens becomes white. In mature cataract, whole of the lens becomes white, and we get it as by the name of a pearly white cataract. Whenever you get a pure white cataract, then it is known by the name of pearly white cataract, and it is a type of a mature cataract. Okay? In this mature cataract, you cannot tell that this mature cataract was made up of nuclear cataract or it is result of posterior subcapsular cataract, because in immature cataract we can say that the nuclear part is opacified, okay, this is nuclear, the cortical fibers are opacified, this is cortical, but ultimately whenever the lens or the cataracts, yeah, so these are the morphological classification of the senile cataract we were discussing, like the nuclear, posterior subcapsular, cortical, posterior polar, anterior polar. These all are the parts of the or the classification of the senile cataract. Now we will discuss through some pictures some of the pathological reasons. As I said, senile cataract is basically a part of normal aging process, so it cannot be considered pathological as such. The other causes of cataract, the pathological processes or the reasons behind the cataract, will discuss them. And you must recognize the pictures, because most of the time they are not going to give you some hints on the question. They can give you them as the spot diagnosis. If they give you the hints, you can still solve the question, but you must know how the look like of the cataract is whenever a particular systemic disease they are asking about. So I want you to focus on these two images. So there is somewhat similarity in both these images, so I have kept it together. In the first image, can you appreciate this spoke-like structures, these spoke-like opacities in the lens? This is a star-shaped opacity in the lens. This is seen in the blunt trauma to the eye. Whenever there is blunt trauma to the eye, you get a cataract picture like this. Okay, so this is known by the name of rosette cataract. This is known by the name of rosette cataract, seen in the blunt trauma to the eye. And in this image, a similar looking image, this is seen. This is known by the name of sunflower cataract, and it is seen in Wilson's disease. This is seen in the Wilson's disease. So how to differentiate between these two? The cataract seen due to the blunt trauma, it has very regular and stellate petal-like appearance. That is the rosette cataract. This is very organized petal-like appearance which is seen in this cataract and is known by the name of rosette cataract. And this one is the sunflower cataract which is seen in the Wilson's disease. This is known by the name of snowflake cataract. Snowflake cataract, which is seen in diabetes mellitus patient, especially type 1 diabetes patient. This is snow. Okay. Can anybody tell me which type of cataract is this? I'll give you the name of this cataract. Can you tell me where it is seen? This is seen in myotonic dystrophy. This lens is showing polychromatic luster. Okay, this is showing different colors to this, like a gift wrapping paper. It looks like a gift wrapping paper having this multiple colors to it, and it is giving polychromatic luster seen in the myotonic dystrophy, known by the name of Christmas tree cataract. Christmas tree cataract. This polychromatic luster, which is shown by the Christmas tree cataract, is also seen in complicated cataract. Complicated cataract. What is this complicated cataract is? Complicated cataract is the type of cataract which is caused due to some other pathological or the inflammatory condition of the eye, like uveitis. Like uveitis. This polychromatic luster in the complicated cataract is known by the name of breadcrumb appearance, and this polychromatic luster in myotonic dystrophy is known by the name of Christmas tree cataract, while in this polychromatic luster in complicated cataract is known by the name of breadcrumb appearance. Okay. What are these two images? These two images are the images of congenital cataract. The image in the right is, as you can appreciate, these are bluish color dots which are present throughout the lens. This is blue dot cataract, which is the most common cause of congenital cataract. But it is not visually significant. It is not visually significant. So patient usually never complains of visual loss due to it. It is an accidental diagnosis. Patient might have come to you for another problem, and on slit length you see there are bluish dots which are present throughout the lens, and this is the blue dot cataract. And when you ask the patient, they say, I don't have any problem in my vision, I have come for my dryness or for my sty or anything else, but the patient has not come for his decreased vision because it is not visually significant. But the second most common cause of congenital cataract, that is the lamellar cataract, is visually significant. So we can have two one-liners here, which is the most common cataract congenital, that is the blue dot cataract, which is the most common congenital cataract, which is visually significant, is this lamellar cataract. And in this lamellar cataract, you can see these some spokes which are present. And what is the best way to diagnose lamellar cataract is, just like as we discussed in senile cataract, the central part will be opacified, but the peripheral part will be transparent. Okay, but this is not in nuclear cataract. Some of the findings are similar, but in nuclear cataract you will see some color changes also, as we discussed, green, yellow, amber, and brown. But in lamellar cataract you will have central opacity. Peripherally it will be clear, but it will have no color changes which will be present. And on slit it will be seen like this. The central part will have cataract, and it will have lamellae. It will have opacity in the form of these lamellae. That is why it is known by the name of lamellar or zonular cataract. It has two names, lamellar and zonular cataract. Okay. Now these were the types of the cataract or the appearances of cataract. Now we come to the most important part of the lens, that is the cataract surgery, because earlier most of the questions were towards the identification of the cataract, but now the momentum has shifted towards the surgery. So before going towards the surgery, I would like to give you a previous page. Okay. I will want to give you a brief discussion about the surgery of the cataract. The surgery of the cataract, it is divided into two parts. One type of cataract is intracapsular cataract extraction. Another is extracapsular cataract extraction. As the name suggests, extracapsular, it means we are not touching the capsule. It is extracapsular. Okay, it is not involving the capsule. So there are two main surgeries, intracapsular, extracapsular. The intracapsular is mostly obsolete now, not used, but extracapsular is the surgery which we use, but it has another classification to it, another subtypes. Extracapsular cataract surgery is again divided into three. So earlier, the earliest surgery to do in cataract was couching, where the lens it was pushed backwards into the vitreous cavity, or it was removed out of the eye, or it was pushed back into the vitreous cavity. That was known by the name of couching. Then developed intracapsular cataract surgery, where whole of the lens, its capsule, its cortex, its nucleus, they were removed from the eye. It was intracapsular cataract. Then more advancements came, and the surgery developed was extracapsular. That the surgery was extracapsular, so the posterior capsule it was left as such, and the nucleus and the cortical fibers they were removed. And in the extracapsular, the first surgery which was introduced was known by the name of conventional extracapsular surgery. Then the advancement came to this surgery also, and we developed a surgery that is manual small incision cataract surgery. And further advancement came to it, and the surgery came out of this was phacoemulsification surgery, which is now the surgery of the choice, which is done most commonly in this cataract. Okay, so this is how the types of the cataract surgery they got involved. Earlier we used to do intracapsular, then came extracapsular, where the capsule was left as such. Out of this, conventional was first to come, then was manual small incision, and now we are doing the phaco surgery. So what we were doing in the intracapsular was we used to remove this whole of the lens as such. But what are we doing in the extracapsular surgery is, this is the lens. We are creating an opening in the anterior capsule, a circular opening in the anterior capsule. We are putting our instruments through this opening. We are removing the cortex and the nucleus, and we are leaving this posterior capsule as such. We are not disturbing this posterior capsule. And again, through this opening, we are putting the IOL. We are putting this IOL inside the head. So this is the anterior capsule. We are making an opening in it. We are removing the lens and the nucleus, cortex and nucleus, and we are putting this intraocular lens inside this cavity above the posterior capsule. Okay. The conventional extracapsular surgery is also not done now. It used to contain a very long incision. It was not self-healing. It had a incision of up to 10 to 12 mm. It was not cell sealed. We had to suture it, and again, it is not done now. The surgeries which are done now are the phacoemulsification and small incision. Small incision is done by because many of the centers or many of the hospitals who do not have a phacoemulsification machine, we do SICS. Otherwise, phacoemulsification is the surgery of choice. Phacoemulsification is a machine-based surgery, while manual small incision, as the name suggests, it is a manual surgery. It does not require any machine. Both these surgeries have a self-sealing incision. Both have self-sealing incision. We need not to suture in both these type of surgery. Now we will quickly revise these two type of surgeries. First, we have pictures of the phacoemulsification surgery. So how do we do phacoemulsification surgeries? Firstly, we give a clear corneal incision. As you can see in this image, we are giving a clear corneal incision with the help of a blade. First step is giving a clear corneal incision with the help of this entry blade. This is known by the name of keratome or entry blade. Okay, we are entering into the eye. We are entering into the cornea. And whenever this we are entering into the eye, can you imagine whenever we will enter the eye, the aqueous humor will move out. So we maintain the chamber with the help of ocular or the viscoelastics. We will maintain the chamber and we have entered the eye. Next step, what we will do is we discussed it. We have to remove the anterior capsule. Now to enhance the visibility of the anterior capsule, as you can see, it is blue in color. We stain it with prepan blue dye. We stain it with prepan blue dye, so we get a visualization of the anterior capsule. It becomes blue because of this dye, and then we can remove it. In the cut section, we'll create this opening, but whenever we are looking at this image, how we will remove the anterior capsule is we'll make a vertical cut, and then through the vertical cut we will take this flap. As you can see in this image, we are moving this flap in the circular direction, and then we will get an opening, a circular opening like this. Can you appreciate? We will take this flap like this 360 degree, and it will create an opening in the anterior capsule. It is done with the help of this instrument. This is capsulorhexis forceps, and can you see in the tips it has tooths. It has tooths in its tip, that is capsulorhexis forceps. Or it can be done with the help of a 26 gauge needle, 26 gauge needle which is bent. Okay, we can bend it with ourselves, a 26 gauge needle, and this is known by the name of cystitome. This is a cystitome. These are the two instruments by which we can do the capsulorhexis. After capsulorhexis, we have to separate the nucleus from the posterior capsule. We have to separate the nucleus and cortex from the posterior capsule. Okay, so it is done with the help of the process which is known by the name of hydrodissection. What do we do in hydrodissection is we introduce a syringe cannula. There is normal saline ringa-lactate fluid which is present in this syringe. We will go beyond the anterior capsular opening and we inject this water with force. We inject this water with force which separates the nucleus and the cortex from the posterior capsule. This is hydrodissection. And when it is separated, then we introduce this phaco probe. This is the phaco probe which is attached to the phaco machine, and then it basically removes the nuclear part. It emulsifies it. How does it remove it? It emulsifies this part and then it sucks it into it. Okay, so it emulsifies this nuclear part and removes the nuclear and the cortical fiber. Okay, and whenever we have removed the nucleus part, which is which is a very resistance or a tough part, we are sometimes left with this thin cortical fibers. We are left with this cortical thin fibers, which we can remove with the help of irrigation and aspiration. Which we can remove by irrigation and aspiration to remove the cortex. And it is done with the help of these two instruments. These are for irrigation and then we can implant the IOL. We can implant the IOL and then we dial it. We can move this IOL once it is inside the eye. We can move it to give its normal position with the help of this IOL dialer. So what are the main highlights of this phacoemulsification? It is a self-sealing surgery. It is done with the help of a machine. What is the size of this incision which we are giving in this phacoemulsification? What is the size of this incision? It can range from 1.8 to 2.8 millimeters in size. It is a clear corneal incision and it is a self-sealing incision. Now, what are differences of phacoemulsification from the manual small incision surgery? So, the manual small incision surgery, the first step is, in the first step, we ligate or we apply a suture in the superior rectus muscle. We apply a suture in the superior rectus muscle, and this is known by the name of superior rectus forceps. Do not confuse it with the Uttarata or the rexus forceps. This you can see it is a bulky forceps, and in the capsulorhexis forceps, it had tooth only in its anterior-most part. Okay, but here this superior rectus forceps, it is bent. It has tooth and it is bent and it is a bulky forceps. It is to apply a bridle suture in the superior rectus. How will it help it? When we will apply a suture to the superior rectus, it will hamper the function of the superior rectus and the eye will move downward, giving us a more view to operate. Because we, in the phacoemulsification surgery, we do not use the sclera, we do not apply any incision to the sclera, but in manual small incision surgery, we have to apply suture in the sclera also. That is why we want a better view of the eye. That is why we apply the superior rectus forceps. Now we will do the peritomy. That is, this is the next step, that is peritomy. We will give the incision in the conjunctiva. We will remove the conjunctiva. This is known by the name of peritomy with the help of this scissors. Okay. And after giving this incision or the peritomy, we will give an incision in the sclera. In the phacoemulsification, we were giving clear corneal incision, but in SICS, we will do the scleral incision. And after giving the scleral incision, we will form a sclerocorneal tunnel. We will make a sclerocorneal tunnel with the help of this instrument. Okay, with the help of this crescent knife, we will go from the sclera to the cornea and then we will enter in the anterior chamber. So it will form a sclerocorneal tunnel. Firstly, we will go into 50% thickness of the sclera. Then we will go in the stroma of cornea and then we will dip down this instrument with the help of entry blade, which was shown in the phacoemulsification surgery also, and then we will enter the anterior chamber. So here we will make a sclerocorneal tunnel, which will give a self-sealing incision. So the difference between phaco and SICS is, in SICS we are making a sclerocorneal tunnel, while in phaco we were giving the clear corneal incision. Okay, and again the further steps will be same. We will put the dye in the eye. We will do the rexes, then we will do the hydrodissection, and now we do not have any phaco probe. After dissecting, after removing or after separating the nucleus from the posterior capsule, we have this instrument which is known by the name of wire vectis. This wire vectis will remove the nuclear and the cortical lens as a whole. It will remove this nuclear lens as a whole with this instrument, that is the wire vectis. That is why it is known by the name of manual surgery. And then after we have removed this lens and the nucleus and the cortical fiber, we will remove the remaining of the cortical fiber. Here we were using the IA, as you can remember, these were the irrigation and aspiration probes which were used in the phaco. Here we use a Simcoe cannula. Here we use a Simcoe cannula. It is attached to a syringe. Here we have attached a syringe. It will give at one end it is attached to syringe and at one end it is attached to a drip, and it will aspirate, it will irrigate and aspirate the remaining cortical fibers, and then we can put some IOL. So what is the size of incision in SICS? It is 5.5 mm to 7.5 mm is the size of incision in SICS, while it was 1.8 to 2.8 in phacoemulsification. Both are self-sealing. Now we have this long incision in this, so we can put the IUL. The IOL size is also like 5.5 to 6 mm in size. So we can put the IOL as such in SICS surgery. But in phacoemulsification, since the size of the incision is small, we cannot put lens as a whole. So for putting IOLs in phacoemulsification, we need rollable or foldable IOLs. So they can be accommodated in a small incision size. So here we use rollable or the foldable IOLs in the phacoemulsification surgery. And this is the latest addition to the cataract surgery, that is the femtosecond laser assisted surgery. It does 2-3 steps of cataract surgery. Firstly, it can give the clear corneal incision. It is used for the clear corneal incision. Then it can do rhexis, capsulorhexis, okay, and it causes fragmentation of the nucleus. All these are a function of the laser. So, and then once we get these 3 steps done by the femtosecond laser, we'll proceed with the phacoemulsification surgery, and then we can proceed with our cataract surgery. Okay. These are the some methods to do the IOL calculation. This is the most commonly used SRK2 formula. This is the P stands for power, A stands for a constant, which can be constant for a particular machine or a particular surgeon. L is the axial length of the eye, and K are the keratometric powers. These are the keratometric. SRK-T formula, you have to remember some of the formulas which are used in different types of the eyes. In cases of high myopia, we use SRK-T formula. In hypermetropic eyes, we use Hoffer-Q formula, and for post-LASIK patient, we use Hades formula. These are the IOLs. This is a monofocal IOL. Monofocal IOL meaning it will give a far vision, and for the presbyopic vision, patient will have to use the glasses. This is going to give the patient distant vision. But here you can see IOL having multiple circles. This type of IOL is known by the name of multifocal IOL. It gives both the far and the distant vision. This IOL, which has 3 dots in its periphery, it is known by the name of toric IOL, which are used in the cases of astigmatism. And this is the why these 3 dots are given, because we have to align these dots, this part of the lens, towards the axis of the cornea if we want to reduce the astigmatism. Okay, this is the post-operative complications. There are many complications of the cataract, but 2 are worth knowing. One is the after cataract or the posterior capsular opacification, and other one that is the most dreaded one is this endophthalmitis. Endophthalmitis. Please write down the most common cause. What is the most common cause of endophthalmitis? Patient will present with eyelid edema. Patient will present with hypopyon, conjunctival injection, and loss of vision. What is the most common cause of endophthalmitis? Anybody? Staph epidermidis. Yes, staph epidermidis is the most common cause of the post-operative endophthalmitis. How to treat endophthalmitis is, whenever a patient comes to you with endophthalmitis, he will come to you after 2 to 7 days of surgery. Why not immediately? Because bacteria need some time to grow. Patient will come to you after 2 to 7 days of surgery with decreased vision. First step we have to do is we have to record the visual acuity, because whatever the visual acuity of the patient is, the treatment modality will change depending upon the endophthalmitic vitrectomy study, that is the EVS study. If the visual acuity is better or equal to hand movement, we will put the patient, or we will give intravitreal antibiotics to the patient. Will repeat them after 24 hours. And we will take a vitreous biopsy for the microbiological investigation, and we will give some intravitreal antibiotics. If the vision of the patient is less than hand movement, but it is perception of light, we will do vitrectomy. We will remove the vitreous and we will give intravitreal antibiotics. If the patient presents with no perception of light, patient denies any vision, he denies any perception of light, we have to go for the destructive procedure as enucleation or selection. So this is based upon endophthalmitis vitrectomy. Okay, and this is the most common complication after cataract surgery, that is the after cataract or posterior capsular opacification. As you can see, there is opacification in the posterior capsule. Why does it happen? Because sometimes whenever we are doing the cataract surgery, some of the dense epithelial cells, they remain as such, they are not removed completely, so they are basically they are left there only, and then they can divide and they will lead to the posterior capsular opacification. How it is treated? It is treated with the help of anti-YAG capsule. It is done with the help of, we create an opening in the central part. How much opening we create? We create a 3 to 4 mm opening in the central part. Please tell me, why do we keep the opening as 3 to 4 mm only? And then we will close the session. Why do we create the 3 to 4 mm opening in the central part only? We are giving this 3 to 4 mm opening because this is a mesopic pupil size. This is a mesopic pupil size. So we are clearing the visual axis of the eye only. We are clearing the central part, which is the mesopic pupillary size, and rest is covered by the iris. So we are basically clearing the area which is opening in the pupil, so the patient will have a good vision. We are clearing the visual axis of the eye, and this is the normal pupil size. So we are removing or getting an opening of 3 to 4 mm. So this was about the lens and some of the pathology, some of the morphological classification of the. This is the endophthalmitis management slide of the lens. Okay, so this is my WhatsApp number. If any of you face any problem in any part in for solving MCQs, for any difficulty you get in ophthalmology part, feel free to connect me. I will try to answer as soon as possible. And this is a slide of the endophthalmitis management again. So if the patient has hand movement vision, we will give him intravitreal antibiotics. If he has perception of light, we will remove the vitreous and also intravitreal antibiotics. If there is no perception of light, we have to go for the reconstructive procedures. Most common causes staph epidermidis, and there is another bacteria, that is Propionibacterium acnes. It leads in Propionibacterium acnes. What is the most common cause of endophthalmitis is bacteria. From where this bacteria we are getting is, we are getting this bacteria from our own ocular flora. So our own ocular flora, staph epidermidis is basically a commensal. Staph epidermidis is basically commensal in our eyelashes, from where we are getting this staph epidermidis. If when we are not uh, basically maintaining a proper hygiene, it can be introduced inside the eye and it can induce an inflammation. Propionibacterium acnes causes late onset endophthalmitis. Late onset endophthalmitis is done by Propionibacterium acnes. It is a low virulent bacteria. It sometimes get deposited in the posterior capsule of the eye, and whenever we are doing, a patient presents to you with you PCO, you are doing NDA capsulotomy, and this Propionibacterium acnes can then, because of the opening in the posterior capsule, it can start dividing and it can lead to late onset endophthalmitis. And also remember, P. acnes is the old name of the bacteria. Now the name of this bacteria has been changed to cutiform acnes. So till now you were getting the questions in the name of P. acnes or Propionibacterium acnes. Now you can get the question in the form of cutiform acnes. So do not get confused because this is the new name of the Propionibacterium. Okay. So this was about the lens, and if you feel any problem in any part of the ophthalmology, you can contact me. Okay. So thank you for this session, and I hope this was a helpful session for lens. And lens is more of a factual chapter, so it's more of you have to remember it, then you have to understand it. Okay. So all the best to all of you, and I hope this session was helpful. Thank you.